presentation. Anyway, just for as usual, we will have a visual. Is screen visible?
Yes, sir.
So, anaphylaxis and anesthesia. Defined as a severe, potentially life-threatening systemic hypersensitivity reaction. Okay, but it need not always be severe and potentially life-threatening. Sometimes you escape with a simple angioneuritic edema like swelling in the lips and severe itching, and then it terminates itself. And but the real anaphylaxis, which is very very severe, that is why there are gradings are given. Grade 1, grade 2, grade 3 is given because it can occur in severe different types of presentation. But the most dangerous or the most severe form is the life-threatening systemic hypersensitivity. And the pathophysiology happens, as he rightly said, by immunological, non-immunological, or idiopathic mechanism. And IgE-mediated anaphylaxis caused by cross-linkage of IgE resulting in degranulation. And when you are exposed to an allergen, first it activates the T helper 2 cells. That is how the whole project, the sensitization occurs. And that produces the stimulation of antibodies against the IgE antigens. So the IgE binds to what is called the FcRA receptors on the surface of the mast cells and basophils, causing first sensitization. I'll show you a good picture to understand this more than reading the lines here. So the initial sensitization has no clinical manifestation. That is how when you just start injecting, many times we are caught unaware, because that is why in anesthesia it is always safer to inject all the drugs in a very slow fashion, whether you are injecting agent or your relaxant. I have seen many people just like that pushing the whole drug in jiffy. Within a matter of less than a second, they will push the whole drug. That habit should stop. If you do it slowly, you will only be sensitizing, and at the time you can see a sudden rash or anything appear, which will be very mild form, and you can stop further injection and prevent a major anaphylaxis. So it is a better practice to always go with a slow injection, observing the patient for the response. And this is the point that you have to clearly understand. After the initial sensation, the re-exposure occurs by the larger dose that you continue. So the initial dose that goes in causes the sensitization, and the complete total dose that you calculate and give causes the re-exposure, and that results in the binding of the IgE aggregates to the stimulus and causes the basophil to degranulate. And once the basophils and mast cells are degranulated or ruptured and broken down, they release mediators like histamine, prostaglandins, proteoglycans, and cytokines, which are the main chemicals responsible for the manifestation of the violent form of anaphylaxis. In the non-IgE mediated, the hypersensitivity happens through IgE and immune complex complement mediated pathways, which is not actually the real anaphylaxis. And the non-immunological mechanisms are by direct stimulation of mast cells by the causative agents itself without going through the IgE route. So this picture I'm going to shows the two stages of the anaphylaxis. First phase is the sensitization phase. Here, if you see, this is the allergen that it may be a muscle relaxant, or it may be an antibiotic, or it may be a drug which can potentially cause an anaphylaxis, or a incompatible blood infusion. Some allergen is there that is captured by antigen presenting cells, and that goes to the T helper cells, and T helper cells, 2 cells are stimulated, which trigger the release of cytokines, and then the plasma cells. These are the receptors, Ig receptors, which are just floating freely in the plasma. And the plasma cells which carry that, they bring it to the mast cells and just fix the receptors on the surface of the mast cells. So that is what is called the FCERI cells. So it happens on the mast cells and basophils. At this stage, there is no clinical evidence of any reaction like angioneuritic edema, itching, or bronchospasm, or hypotension. Nothing will be there. So the initial preparation is the Ig receptors are fixed onto the cells of the mast cells and basophils. Then subsequently what happens, when further allergen is injected, then they come and occupy these receptors, and then that triggers the release of all the mediators by the cells getting broken down, both the mast cells and basophils getting broken down, and all the mediators which are told in the previous slide, like histamine and other cytokines, they cause this problem of various system involvement. And in this next picture also, you will get a good idea. The antigen comes here. It is first captured by antigen presenting cells. You can see it is swallowed like a amoeba getting the food into that, and then it releases or gets the receptor, Ig receptor ready on the CD3 lymphocytes, and then that goes to release cytokines here, and then the B lymphocytes, they carry this receptor on the surface, and then from this the receptors are now attached to the mast cells and basophils, and again the antigen has to come and interact with the receptors that now have been amplified onto the surface here, then only the degranulation occurs. So up to this phase, it is sensitization phase, and when you inject more and more drug, then only the drug becomes, the re-exposure occurs and degranulation occurs. I hope this picture gives you a good idea about to remember how the whole thing happens. So you must remember that up to this stage, from here 1, 2, 3, 4, up to 5 stage, it is a sensitization phase. At that time, you will not have any clinical evidence. From 6 and 7, then only the degranulation occurs, and that is the time when severe anaphylaxis will happen. So if you are careful and if you inject your drugs in a slow fashion, you can pick up the anaphylaxis in a very mild form. Immediately you can notice some swelling occurring. Even in anesthetized patients, sometimes you can see some reaction happening along the intravenous channel, and the patient's face, lips may start swelling up. And if you stop at that stage, you can avoid a very severe reaction or the severe form of anaphylaxis. Now, what are the risk factors or triggers that happen? The risk factors are a history of atopy, that is, patients who are prone for any allergy. That is why we must always ask in the history whether you are allergic to any drug given. NSAIDs are very common, and in the olden days, penicillin allergy, all the patients used to say that I am allergic to penicillin, I am allergic to sulfa, because they would have taken them orally and they would have experienced a very mild grade of anaphylaxis in the form of swelling and urticaria, and that doctor would have told that you are allergic to this. Luckily, it stopped at this stage. Don't take any other, because the second exposure or third exposure, repeating of that will result in the severe form. And that is where they say it is the first exposure and re-exposure happening by oral route. Whereas in anesthesia, we give all the drugs mostly intravenously. So the first exposure and re-exposure is dependent only on the amount of drug that is injected into the body. So that is how the whole process occurs. And the common triggering drugs are NMDA, antibiotics, and latex. Of course, latex allergy is very, very common in the Western world, not that much in our country, but of course, it is also being recognized now here. And less commonly, you can get allergy from chlorhexidine, colloids, and blue dyes, heparin, protamine, and oxytocin. And so, when you give all these or when you use these agents, you always exercise a caution so that you do not know which patient is going to react in a very violent form. So, as a universal rule, always when you inject a neuromuscular blocking agent or antibiotic, always inject a small dose, wait for some time, and then go ahead and give the rest of the dose. The common muscle relaxants notorious for causing this anaphylaxis are acroneum and hexamethronium. And how do you diagnose anaphylaxis? It's a clinical diagnosis. And laboratory tests are not useful in diagnosing anaphylaxis at the time of presentation. But when something seriously happens and the patient dies, and you claim that it is because of the anaphylaxis, you must always take a blood sample and keep it ready so that you can prove by the presence of an enzyme called tryptase that it could be anaphylaxis. That is the only savior for you. So whenever you suspect anaphylaxis, always take a blood sample and keep it ready so that you can analyze it for the enzyme tryptase later on. Now, patients with acute onset, they will have clinical signs of respiratory compromise, cardiovascular instability, and mucocutaneous or subcutaneous signs. These signs may present in isolation or in combination. So it may start with circumoral swelling, and then it may go on to produce severe wheezing. Then it may go on to produce a sudden hypotension and bradycardia or tachycardia. All these things may happen in a sequential form, or it may come together all at a time, or it may just produce a mucocutaneous swelling and then stop, and then after half an hour, patient may. So it can occur in any form. So that is the way we must always watch this patient and not just write it off that everything is settled. And it can be from other related things like periatric surgical causes, and so you don't take the blame all the time that your drug only is the culprit. So look for other possibilities also, and it should be suspected when there is unexplained hypotension, refractory to vasopressor, or unexplained difficulty in getting a bronchospasm relief. So if these two things occur, and if you have used any offending agents, then you always think that it could be part of anaphylaxis. So grading is by Ring and Nesper. They have done the grading, and there they have graded it into 4 stages: grade 1, 2, 3, 4. And in the grade 1, it is mainly the mucocutaneous signs like erythema, urticaria, and angioneuritic edema. The grade 2, it starts affecting the organs with like bronchospasm and hypotension. Grade 3 is much more serious thing, producing arrhythmias, cardiovascular collapse, more bronchospasm, and also severe edema all over the body. And grade 4 can be a sudden cardiac arrest also. So if this happens straight away after giving the drug, you are in deep trouble, because this is a very, very serious condition, and you have to act very swiftly to save the patient from death. So what is the immediate management? Is mostly supportive, stop the triggering agent administration, secure a good airway, give high flow oxygen, and adrenaline or epinephrine is the most important savior. Examination, they ask you which is the drug you should administer immediately if you suspect anaphylaxis. Is the only savior is epinephrine. And the administration of epinephrine is based on the grading. So you don't blindly inject a large quantity of adrenaline directly. So the grading gives you the dosage. So for grade 1 to 2, where there is a generalized mucocutaneous signs and bronchospasm, hypotension, you can give 5 to 20 mics IV for children 1 to 5 micrograms IV. If it goes to grade 3, then you give 100 to 200 mics for an adult and 5 to 10 mics for a child. With grade 4, you can straight away give 1 milligram, that is 1 ampule, 1 ml, you can give IV, and 0.01 milligram per kg as the IV dose for children. And if intravenous access is not available, then you can give IM also. Don't wait for to secure an IV access. You give IM 10 micrograms per kg, maximum 0.5 milligram or 0.5 ml, and for that is the adult dose, IM dose, and child less than 12 years 300 micrograms, less than 6 years 150 micrograms. So administration of epinephrine should be done in a titrated way like this, because if you inject too much of adrenaline, response to adrenaline diminished in patients on beta blockers or patients who have already been on ACE inhibitors, and those who have on a spinal blockade with a high level of spinal block, they may not respond to the adrenaline. So excessive administration will cause ventricular arrhythmias, pulmonary edema, and hypertensive crisis. And that is the reason why you have to first grade the severity of anaphylaxis and decide the dose. The adrenaline has a narrow therapeutic window, so it may produce more serious consequences by the overdose. And the optimization of cardiovascular effect by initial resuscitation of fluids with 20 ml per kg and positioning the patient for improved venous return. That is the head down position and fluids are the two methods by which you can improve the cardiovascular status. And if you are not able to non-invasively measure the blood pressure, go in for an arterial line and try to, that is for more severe cases, grade 3, grade 4 cases. Think of starting and inserting an arterial line and also central venous line for vasopressor and inotropic administration. And in cases where anaphylaxis has happened because of rockronium, the reversal agent sugammadex is a very good agent to control the anaphylaxis and reverse it. So instead of relying on adrenaline, you can straight away inject sugammadex to reverse the anaphylactic reaction of rockronium. So always keep sugammadex ready when you are giving rockronium so that you can immediately inject it and reverse the anaphylaxis before it becomes very severe. And in cases where there is a resistant hypotension, you can give other vasopressors like noradrenaline, atrimenol, or vasopressin. And if the patient is taking beta blockers and he is not responding to your adrenaline, then you have to give glucagon, which will reverse the effect. And for resistant bronchospasm, you can give, apart from inhaled salbutamol, you can even give intravenous salbutamol. And once the crisis is somehow managed, then comes the role for steroids and antihistamines that you can start giving. Steroids, you can give dexamethasone or hydrocortisone in doses of hydrocortisone 2 to 4 mg per kg. Dexamethasone, which is a long-acting drug, you can give 0.1 to 0.4 milligram per kg. They act by inhibiting the genes which encode pro-inflammatory proteins and may be affecting the what is called the biphasic reaction of the allergen. That is, initially it seems to be subsiding. Later on, it may again get released and it may start affecting. That is called the biphasic response. And the oral antihistamines have a better side effect profile than the IV antihistamines that are given. And if you combine it with the H1 and H2 receptor blocker, like diphenhydramine hydrochloride, is called commercially as Benadryl, and also with ranitidine, then it may have more effect than giving the H1 antagonist like chlorpheniramine or diphenhydramine alone, especially for cutaneous manifestations, and urticaria is very well controlled by this. And the intravenous antihistamine has the risk of producing hypotension, especially if you inject it very fast, or if it goes into the extravasation into the tissues, it may cause tissue injury and necrosis. And intraoperative anaphylaxis can occur. Try to finish the surgery as quickly as possible by discussing it with the surgeon. And for post-operative care admissions, be organized for monitoring, especially grade 3, grade 4 anaphylaxis. You must monitor the patient up to 32 hours because, as I told, there can be a what is called the biphasic reaction. As soon as you start treating it, everything seems to get subsided. But later on, after about 10 hours, 12 hours, 24 hours, again a similar picture can happen, and that is what is called the biphasic reaction. So these patients should not be discharged immediately, they should be kept under observation. And several hypotheses for this biphasic reactions are inadequate treatment at the initial reaction, release of late phase mediators from immune cells, delayed absorption of antigen from the gastrointestinal tract into systemic circulation, and activation of secondary mediator pathways. So these are all the theories that are proposed for the biphasic reaction. And plasma total tryptase level may help to support your diagnosis. So you must always try to keep the blood sample. So tryptase levels, they increase within 15 minutes to maximum 120 minutes. Up to 2 hours, they start increasing. And then they start declining to the baseline level by 24 hours. That is why as soon as you suspect, you must take the blood sample and keep it ready. If you take it very late, say after 24 hours, you may not find the tryptase in the blood at all. Then your diagnosis or suspicion of anaphylaxis will be totally defied. So always keep the blood sample ready so that it will protect you in case of any legal issues happen or consumer court problem happens. It can always be proved by the levels that have been taken at the very early stage. And a definitive cutoff value for the diagnosis has not been determined. So you must take two blood samples, first within the first hour, that is 60 minutes, and the second at 24 hours, and they start declining. So the first one should always be very high. So anaphylaxis is likely if the first sample is significantly higher than the second. So if it shows a declining trend at 24 hours and a very high value at first hour, then it always confirms that it could be anaphylaxis. And if the tryptase level remains increased beyond 24 hours, it may indicate a late onset anaphylaxis or biphasic reaction. And that may be also due to mastocytosis or clonal mast cell disorder. Sometimes the mast cells themselves may be at fault. So in that case, they will be constantly triggered and they will be releasing the reactions like histamine and other agents. So the tryptase will be persistently high. Then you have to suspect something faulty with the mast cells of the patient. Another test is the elevated plasma histamine level, which also can be assessed at the time of anaphylaxis. So two tests that you have to keep in mind is measuring the tryptase level as well as the plasma histamine level within 2 hours of suspecting anaphylaxis. That is very, very important. And prevention can be by identification of possible allergens and referring the patient to the immunologist or a center specializing in that allergy. And it can be carried out in all high-risk patients before any future anesthesia. Supposing you have canceled the case after an initial, say, orocutaneous swelling and bronchospasm, you suspect allergy, anaphylaxis, and you have cancelled the case, and the patient requires surgery, comes again, then you can test for the drugs that you suspect to have caused the anaphylaxis and the before the next anesthesia. And high-risk patients are those with history of intraoperative anaphylaxis or known allergy to drugs like which are used in anesthesia. For example, some patients may say, I had one surgery under local anesthesia, a dental extraction. I had severe bronchospasm, hypotension. Then the dentist has to abandon the procedure. Then that patient may be tested for local anesthetic allergy if it is especially the non-amide drugs like esterases. Then you have chances of allergy. So you can avoid that, or you can go straight for a general anesthesia. Or children who have multiple interventions, especially for plastic surgeries or spine surgeries, they may develop because of re-exposure again and again, they may develop an anaphylaxis. And patients with latex or food allergy also, they are prone for anaphylaxis. After an anaphylaxis episode, we should document the whole thing. That is very, very important. Clear documentation of the incident is very important, so that in future you can always say that patient. Some even now you will find some cases having patient allergic to NSAIDs, patient allergic to cephalosporins. All that be written in red ink at the top of the case sheet, so that you can always be careful in their usage or avoid using them in the future. And preventive administration of glucocorticoids or antihistamines for procedures with high risk, like diagnostic procedures involving contrast, or when you want to give antivenom therapy for snake bite, or immunotherapy, or IgE antibody therapy. All these cases, you first treat them with a dose of glucocorticoids like prednisolone, or along with antihistamine, wait for some time and then administer. And even if anaphylaxis occurs, it will be very, very mild in the grade 1 category. So that way you can reduce the severity or even avoid the severity that happens. Okay. So these are the points that I think you should know for this particular topic.